Hi everyone, I'm Jean-Marc Voyadzis. I'm a neurosurgeon specializing in both brain and spinal surgery. And what I'm going to talk to you about today is one of the more common operations that we do in neurosurgery, and that's lumbar laminectomy surgery for the treatment of lumbar stenosis. I'll briefly discuss the anatomy of the lumbar spine. I'll go over the reasons for which we recommend lumbar laminectomy surgery. We'll discuss expected recovery, and we'll also review associated risks. This is a spine model of the lower portion of the spinal column that we call the lumbar spine. And typically, most of us have 5 lumbar vertebrae that are numbered top to bottom, lumbar 1 all the way down to lumbar 5. And then this is the tailbone that we also call the sacrum. The vertebrae are the bony building blocks of the spinal column. And between those bony building blocks, we have these discs that are natural shock absorbers. Behind the discs lies the spinal canal that houses and protects the nerve roots, which travel down the spinal canal of our spine, and then those nerve roots exit and go into our legs and give our legs feeling and strength. The discs play a very important role in shock absorption and absorbing axial loading stresses, and they also play an important role in motion and stability. Behind those discs lie the so-called facet joints that are paired on each side, and they represent the articulations or the relationships between one vertebra and the other, and they allow for natural motion of a vertebral segment. As many of us get older, degenerative changes can set in, and typically the discs are the first structures that start to wear out. The discs start to lose their shock absorbing quality and they start to flatten. And when they do that, they can start bulging backwards, and that can start to narrow the spinal canal. When the discs start to lose their shock absorbing ability, then the normal axial loading stresses of the body over time get transferred to the facet joints, and those joints can start wearing out. And over time, when those joints wear out, they can grow, and that can start to encroach upon the spinal canal as well, and that can cause narrowing of the spinal canal. And then finally, there's a thick ligament on the inside of the bony wall of the spinal canal that we call the lamina. That ligament's called the ligamentum flavum, and over time, with degeneration, that ligament can thicken and calcify and can further contribute to a narrowing of the spinal canal. So there's a series of degenerative changes that take place that can contribute to a concentric narrowing of the spinal canal that contains the spinal nerve roots, and we call that lumbar stenosis. The traditional symptoms of lumbar stenosis are back pain that then radiates into the legs. It can be of a cramping quality, a deep aching quality in the legs that is usually activity dependent. The more you stand and walk, the more the leg pain comes on. Most folks get relief when they sit down or when they lean forward, because leaning forward effectively opens up the spinal canal. So folks can get a lot of relief leaning onto a shopping cart when they're shopping, for example. When the stenosis is quite severe and the nerve roots are significantly compressed, patients can start to get neurological impairment. They can start to get tingling or numbness in the legs, or even weakness in the legs or the feet. If the stenosis is very pronounced, then you can start to get bowel or bladder dysfunction as well. In most cases of mild to moderate stenosis, we usually recommend a series of conservative measures. Losing weight, conditioning your core with physical therapy, avoiding certain aggravating factors or constant wear and tear in the back, heavy lifting, bending, twisting throughout the day. If the symptoms of stenosis are severe despite these treatments, we try various medications and occasionally epidural steroid injections, which can provide acute relief of lumbar stenosis pain. However, when the stenosis is severe and the nerves are severely pinched, those treatment measures are not going to be effective in the long term, and that's when we consider surgical intervention. The traditional approach to surgical intervention for lumbar stenosis is an operation under general anesthesia where patients are placed on their belly, and we essentially remove the bony wall of the spinal canal that we call the lamina and do what's called a laminectomy. The more areas of stenosis that you have, the more levels of laminectomy that you need to have done. When possible, I prefer to do a laminectomy with minimally invasive technique. And that typically means using a small tubular retractor and the use of a microscope or an endoscope. And that allows us to make a very small incision to achieve a decompression of the spinal canal. And we typically can use this technique for 1 or 2 levels and sometimes more. The potential advantages of less invasive techniques is the incision is so small it causes less pain after surgery. We minimize manipulation or damage to the muscles, and we try to preserve as much of the bony integrity of the spinal column as we can to prevent further degenerative changes. The success rate of laminectomy surgery for the relief of lumbar stenosis symptoms is quite good. It's usually about 80%, but it's not 100%. And I tell all my patients, unfortunately, that there's always a chance that the surgery fails to relieve symptoms. On occasion, it's because we've waited too long and the nerves are chronically damaged and we get to them too late, and there are other possibilities as well. But in general, the success rate of laminectomy surgery for the relief of lumbar stenosis symptoms is quite high. When minimally invasive techniques are used, this surgery can be outpatient. Patients can go home the same day for 1 or 2 or sometimes more levels of laminectomy surgery. You have pain for about 1 to 2 weeks related to surgery, and that requires a pain medication and some muscle relaxants because sometimes the surgery can produce muscle spasms. But usually within a couple weeks of surgery, the surgery pain is behind you and you're off those medications. We do impose physical restrictions, typically for about a month after surgery. We call it no BLT, not a lot of bending or lifting or twisting, to give your back a period of rest. And then usually at the 1 month mark, we can begin some physical therapy if necessary to strengthen your core. We'd like to start a weight loss regimen if that's indicated. And then once you're healed from this, you have no significant restrictions. The risks of laminectomy surgery are as follows. Every surgery has a risk of infection. We found at our institution, looking at more than 1,000 surgeries, that with minimally invasive technique, the infection rate is dramatically decreased just because the incisions are so much smaller and we use small retractors that serve as a barrier to infection. Now, everybody's different and some patients are at higher risks of infection than others. There's minimal bleeding from surgery because the incision is so small, we don't see a lot of bleeding. There is a small risk of a hematoma that can form after surgery, which is usually less than 2%. Although a hematoma, if it forms a collection of blood after surgery, it can irritate the nerves and sometimes that can require surgery to evacuate if it happens. The nerves lay in a sac that contains spinal fluid. And when we do the decompression under the microscope, we physically decompress the nerves within that sac. There's a small chance that there can be an inadvertent opening of that sac and that can lead to a leakage of spinal fluid. The risk of that is around 5 to 10%. If it happens in surgery, we typically see it and we can put a suture in the hole that's leaking to seal it up, or we can inject a sterile glue to seal it up. Occasionally we'll have patients lay flat in bed in the hospital or at home to allow that area to completely seal to prevent it from persisting after surgery. A persistent leakage of spinal fluid after surgery can produce headaches, or if it leaks through the wound, it can even cause a severe infection such as meningitis. So we take these leaks seriously when they do occur, but they don't happen with great frequency. Any operation of the lower back carries a risk of nerve injury. That risk is extremely low. It's typically less than 1%. But a nerve injury could be permanent. It could cause permanent pain going down the leg or the foot, permanent tingling or numbness, weakness, even paralysis. But the risk of severe injury, as I mentioned, is extremely low with this operation. There is a possibility, once you're recovered from this, that years later, continued degenerative changes set in and it can cause recurrent narrowing. Or it could cause the vertebra to become malaligned, and that could require additional surgery, either in the form of a redo laminectomy, or if there is malalignment of the vertebra, it could eventually require a fusion. In general, the chances of requiring additional surgery after a laminectomy surgery in your lifetime is usually between 10 to 20%. You're going to minimize those chances if you keep an eye on your weight, you minimize certain physical activities that could put your back at risk of more deterioration down the road.